Right colon and left colon are molecularly different. The right colon is derived from the midgut, the left colon is derived from the hindgut. And therefore, even at very early stages in life, these parts of the colon are molecularly different. We know that the left colon has a higher activation of the EGFR pathway. We know that the right colon has a higher incidence of microsatellite instability. We know that the right colon has a higher incidence of SIMP pathway activation and BRAF mutations. And all of these factors may play a role in resistance or sensitivity to anti-epidermal growth factor receptors. That appears to have an impact on the response rates to biological agents in the metastatic setting. So there are a lot of questions about the differences in outcome between right and left colon cancer, and if the difference in outcome is related to relapse rates in right colon cancers versus left colon cancers. And there's a lot of controversy in earlier stage disease about divergence in outcomes. It does not appear that the left colon is much different from the right colon as far as risk of relapse. But the biggest difference is after a patient relapses from stage 1 or 2 or 3 disease with metastatic disease. Clearly there's a divergence in outcome in metastatic settings between right colon and left colon. Patients with left colon cancer with metastatic disease have a much better prognosis than patients with right colon cancer with metastatic disease. However, the risk of relapse of stage 1 or 2 disease with right colon does not appear to be different than stage 1, 2 left colon. As far as stage 3 disease, the data is a little bit more controversial. If there is any difference, it's not a big difference. A lot of work has been done recently at looking at sidedness and outcome with biological therapy. There is a clear difference in response rate to anti-EGFR therapy based on left colon and right colon in patients with RAS wild-type colon cancer. We know that RAS wild-type tumors are responsive to anti-EGFR therapy, but this responsiveness appears to be dependent on the sidedness. Patients with right colon cancer who receive anti-EGFR therapy in the first-line setting, based on multiple clinical trials, including the FIRE3, CLGB study, 80405, do not appear to derive a benefit as far as overall survival from anti-EGFR therapy in the event of RAS wild-type tumor and BRAF wild-type tumor. On the other hand, patients with RAS wild-type tumor with left colon cancer have a very big difference in survival if they receive anti-EGFR therapy in the frontline treatment in comparison to bevacizumab or in comparison to chemotherapy without anti-EGFR therapy. We're talking differences of about 7 to 10 months in overall survival, which are particularly important in patients presenting with metastatic non-curable colorectal cancer. So at this point, the standards have shifted towards looking at sidedness in the setting of RAS mutation status and patients with left-sided colon cancer who are willing to receive anti-EGFR therapy and whether some of its side effects will derive an improvement in overall survival versus other biological therapy, specifically anti-angiogenic therapy in the first-line treatment. As far as right-sided colon cancer, we do not see a benefit in the first-line setting. And therefore, those patients should receive bevacizumab in the first-line treatment in combination with chemotherapy rather than anti-EGFR therapy. I think the lines are a little bit more blurred later as far as second-line and third-line. In the second-line setting, we still see that right-sided tumors may derive a little bit benefit in response rate. The impact on overall survival with right-sided tumors in the second line as far addition of anti-EGFR therapy has not really been very well supported. And same applies, I would say, to later lines of treatment, refractory settings. Unfortunately, we don't have large sample sizes to look at to quantify the benefit from anti-EGFR therapy from RAS wild-type right colon tumors in refractory disease. But in the left colon refractory disease, there's clearly a very, very substantial benefit in improvement in overall survival from implementing cetuximab or panitumumab anti-EGFR therapy in later lines of therapy. I think we have reached some consensus at this point that anti-EGFR therapy should be strongly considered for left-sided tumors in the first-line setting. I think there is a strong consensus as well that there is a substantial benefit from anti-EGFR therapy in refractory settings, as well as major improvement in response rate in second-line settings in left-sided tumors. What we need to understand and figure out more in the future is how much benefit do we derive from anti-EGFR therapy in right-sided colon cancer in second-line settings and right-sided colon cancer in refractory settings. Even though these are biological agents, they have side effects. And if the incremental benefit is very, very small, even if it's a second line or third line, we should not be considering those agents. It would be particularly important to identify which subgroups of patients with right-sided colon cancer who have RAS wild-type tumors still derive a benefit from anti-EGFR therapy in second line and beyond. I think we also need to understand and figure out what small molecular subgroups in left colon cancer do not derive a benefit from anti-EGFR therapy, despite the fact that they have a RAS wild-type tumor. We know that HER2 amplification, for example, is a small subgroup of about 2 to 5% of patients who are resistant to anti-EGFR therapy. There are likely other smaller molecular subgroups who may not benefit from anti-EGFR therapy, despite the fact that they're left-sided with RAS wild-type. We also need to understand what is the impact of CMS, what is the impact of microsatellite instability, what is the impact of BRAF mutation on response to anti-EGFR therapy. Do we combine other targeted agents with anti-EGFR therapy to overcome specific resistant patterns or pathways to anti-EGFR therapy?